guys because we're starting a little bit later, okay? All right.
Hello, my name is Mackenzie, like Ashley said. I actually was in health occupations class with Ashley when we were in high school. We graduated together, so, and Ms. Schmidley was my teacher, so was in your guys' shoes not too many years ago, more than I would like to admit, but. So I am here today to talk about labor and delivery nursing. Most of you are girls in here, but I see one guy, or two guys, I think. Let's see, yeah. So there are labor and delivery nurses that are males, so it's not totally ruled out. It's just not as common. But there's definitely OBGYNs and FPOBs, which is, oh, I know.
It's on.
Okay. That deliver FPOBs is family practice physicians and OB obstetrics, and they also deliver babies, but they can also take care of regular family practice as well. So just normal doctor visits, like for high blood pressure, anything like that, sickness, illness, all those kind of things. Let's see. So how do I become a labor and delivery nurse? So you guys are in high school right now, and you are in health occupations, and at the end of this, you'll get your CNA, which not all nursing programs require it, but most do. I know I went to Crowder for my associates in nursing, and they do require your CNA before you can enroll in the program for nursing. So definitely you guys are getting a great head start. And then I know that most high schools now offer dual credit classes. So things that you can get out of the way, like, English, some math, stuff like that will help you get a jump start. That way you can go ahead and enroll in the nursing program there. Some like anatomy and physiology, those are things that you have to at least have the first one before you enroll into the program, and you can take the second one if you choose to do so alongside the nursing program. Biology and then microbiology are both required as well. And chemistry, and then lifespan, human development, psychology, that's required in humanities, social, and behavioral science class, and a nutrition class. So just things that you can be more aware going into the nursing program and kind of have a basic background knowledge to do so, along with your just regular, gen ed requirements like history and, all that kind of good stuff. So the Associates of Science in Nursing is 2 years, and that's the track that I chose to go. I know a lot of, I don't know, A+ still a thing, I guess, but that's why I chose to do Crowder and do the 2 years, because I went to nursing school for free, basically. So it was good, but you can also enroll in like a bachelor's nursing program that is 4 years long. So like Missouri Southern, Missouri State, schools like that that offer 4 years. Cox College offers a 4-year bachelor's in nursing program. And the really only difference between bachelor's is that you have more like a business side of education. So like how to be a manager, basically. You can do more educational things like teaching and just things like that. And then you must pass the dreaded NCLEX exam. Well, I got louder right there. And then 1 year for labor and delivery nursing, they would like you to have 1 year of bedside nursing to like just have your nursing experience, because labor and delivery nursing is a little bit more specialized, and you kind of have to have that background knowledge of nursing to be able to do some of the more skills and all that kind of good stuff, or like a postpartum floor. So in Monette, I work at L&D in Monette, and we also do postpartum. So, but like Springfield, they just do labor and delivery. So you have your labor patients, you deliver them, you keep them for their hour recovery, and then they go to another floor. Monette, we take care of the babies and moms after they are born and until they leave the hospital. So it's pretty nice. I like that aspect of it because you get to create a better relationship with your patients and establish a bond with them. But most do not do that. If it's like a bigger hospital, then you're just doing the labor part of it. And then BLS, which you guys do in health occupations, and then ACLS, which is just advanced, and that's more like the medication aspect of like CPR resuscitation, like so you give epinephrine, things like that to stable blood pressure, adenosine to help with heart rhythms, and then also advanced airways. In NRP, it's neonatal resuscitation program, and that's more specific to neonates. So I have some equipment later, like to show you, but little tiny babies are a little bit resuscitating than adults and even infants, because they are new to the world and they're just trying to figure out how to do everything on their own without the help of mom. So even simple things about like maintaining their temperature, their blood sugars, just, you know, new environment that they have to adapt to. So it's pretty cool. It's exciting. It keeps you on your toes. A little nerve-wracking sometimes, but the training of NRP helps you be able to know how to handle a situation if the baby's blood sugar might be crashing, or they're not keeping their temperature up, or their temperature's too high, or whatever. It kind of gives you the basic knowledge to be able to do things to help that baby. Oh, there's a picture. I forgot that I clicked. So, good. How much will I get paid? So a labor and delivery RN, and it's basically the same across the board. So if you're a staff nurse in the hospital, you're going to be making the same as like a new nurse as everybody else. So about $55,000 around, but it can range from 46 to 86 depending on experience. Obviously, anywhere that you're at in the country, different states, obviously you might get paid a little bit more. But let's see, and also like certifications, how long you've been doing it, and then also like if you have night shift differential. Pretty much every place that you ever work at will have night shift differential. It's usually around $3 an hour extra. And then weekend option is a huge thing right now, which is what I work actually. And you get like $7 more an hour for that, and also full-time benefits for just working 2 days a week. So it's pretty sweet. Let's see. What do they do? This is kind of just like basically job description of a labor and delivery nurse. So they direct patient care to mother and baby. Those are both your patients. I know South, they have a nurse specifically that is usually more experienced that goes around and catches all their babies. But as we kind of do it here, we have different roles. We have usually 3 nurses on. One's the labor nurse, one's the charge nurse, and one's the scrub nurse. The scrub nurse usually catches the babies and all that kind of stuff. But within like 15 minutes, if the baby is good, like no needed, like you don't need to resuscitate, no IVs, no concerns there, then they just pass off the baby to the nurse that's taking care of the mom. So do all the care, recovery, cleaning up, doing the baths, let's see, doing testing, doing vital signs, all that kind of stuff. It falls on that nurse. So developing a plan of care for the patient during the stay, and evaluates resources. So a lot of times it's you kind of have to get to know your patients, because if you don't know them, you don't know how to help them. It's kind of mind-blowing to me, the kind of sometimes the things that you think that are second nature, and kind of just duh kind of things that some people just don't know, and that's because maybe they're young, or they haven't had any babies in the family or anything like that. But also you kind of have to think, we are given this education and we are supposed to know this, and they are really not supposed to know this. So you always have to keep that in mind, especially the more that you do nursing. Not everybody has the same background in education as you, so it's always, and me going into the ER setting, I would be so lost. So, somebody coming into my realm, you can't really judge them for not knowing things. So definitely education, giving them resources in the community. If they don't have a car seat or they don't have, formula, there's the WIC program, food WIC program provides, also things like cross lines, just giving them resources, just figuring out what they need, and, being that advocate for them to get those resources that they need to take care of a newborn baby. So. Monitors, documents, and communicates mother, fetal, and infant status to members of the interdisciplinary team. So basically, if a mom is bleeding too much, or the baby's temperature keeps rising, or you're just have any concerns, it's your job to be able to assess that patient and to communicate with the doctors or a respiratory therapist or anesthesia if their pain is not controlled. That's a huge thing during labor. We have to be an advocate for our patients then too, because sometimes they're like, the anesthesia comes in, does an epidural, and the patient is still not comfortable. But the anesthesia's like, I don't know, I did everything I thought, was right, and still they're not under control. But the patient obviously is not comfortable. So you keep calling them, tell them you did all your interventions to help them, moving, all that kind of stuff. And once you communicate that, then they are pretty more understandable to come in and either evaluate the epidural placement themselves or bolus dose the patient. So always just, do your assessments, do your part, do everything you can do. And then when you've ran out of all those options, then definitely don't be afraid to communicate to other people on the team that can help you and the patient. Coordinates maternal patient care holistically, advocating for physical, emotional, and psychosocial needs. So I feel like nursing, in general, you just basically have to be there for the patient, and mentally, sometimes illnesses can be draining on a person. They're struggling with, bad thoughts, things of addiction, which happens, in our realm, and definitely in labor and delivery nursing. Just because you're pregnant doesn't mean that stops. So just being there for them, giving them the resources there. There's a postpartum withdrawal, something, I can't remember exactly what it's called, but anyways, there's a program for women that are come in positive, and they've been positive during their pregnancy, and it helps them get their resources to be able to get their kids back, because usually if they're positive for, drugs like meth, especially opiates, stuff like that, they're not having their baby. But it doesn't mean that they aren't just a normal person, make mistakes, and can get their life back on track, especially when it comes to babies. So definitely help them get the resources and help they need to be able to get back on the right path. Let's see. Also, like, just taking care of the patients during labor, being there, supporting them, getting their ice chips. I know it kind of sounds like, oh my gosh, I'm just getting ice chips, but to them, ice chips are everything. So also wet, cool washcloths, just kind of basically, they get really hot, so just being there to support them during that, just things like that, really makes what a full nurse is, a good nurse is, to take care of all those kind of needs and just make them as comfortable as they can be. So. I kind of talked about this a little bit, but evaluate the learning needs. Everybody has different educational requirements, so basically make sure that they're understanding and providing the proper education techniques and reiterating the fact that they have understood that. So. Let's see, refers patients care to ancillary support staffs and specialists. So if they're needing help with breastfeeding or they have a problem with the baby, like if the circumcision's not being able to be done because of certain anatomy problems, then you refer to urology to be able to do things like that. And just give them the proper setup that they need for that. If they fail like their cardiac screening, you need to refer to do like obviously a cardio, ologist to be able to evaluate and do further testing to make sure that everything's good with the infant. So acts as a preceptor or mentor to student nurses, support staff, and new hires. So all you guys, eventually, if you decide to do nursing, you'll have somebody that's more experienced than you teaching you, and that's part of your job as an experienced nurse to help those new nurses grow and become the nurse that you are currently. Some nurses are better than others, so but definitely it's part of your job and to shape and help grow those new nurses. Let's see. So interpreting fetal heart monitoring and EKG readings. So I think that I have a picture of what I'm talking about. Yep. So the top strip is where it's highlighted in blue. That is the baby's heart rate. So we have monitors, and usually they're external unless it's hard for us to monitor somebody, then we'll do internal leads. But so the heart rate, it kind of looks like little crazy squiggle marks, but that is a normal heart rate for a baby. So usually you guys have seen probably a normal like EKG, like on an adult, how it has that consistent pattern that it goes, the QRST waves, all that kind of stuff. A baby doesn't have that. So what we look for is, it's just kind of like more in depth, but then you guys really need, but variability. Variability means that the baby's oxygen and heart status is good. So they're not running on oxygen, because labor can be really stressful on the infant. Especially if there's a cord, because the cord and the placenta is the baby's lifeline. So that provides oxygen, blood flow, everything to the baby. The placenta is made specifically for that baby, so it's pretty awesome that we create a specific organ just to sustain an infant's life inside of us. So that placenta is that baby's lifeline, so all that blood flow and the oxygen that comes from that placenta helps the heart rate be normal. And then also those big hills that you see up top, that's called accelerations, and that's a good sign that the baby's doing good inside mom. So if you have a line and a baseline that's, let's see, I think that one, I can't really read it too well, but like 150 it looks like the baseline is, and if it goes below 150, and that's called a deceleration, and that is a sign that could be concerning, that the infant is not doing so hot inside. So definitely we have interventions to help that, but if it continues, then obviously we need to get that baby out of there. So usually involves a C-section. So this, I don't know if it's open or not. I'll just go ahead and open it. I was talking about eternal and internal leads. Oh gosh, sorry. This is an internal lead that goes on the baby's head. So you basically, it goes inside the vagina, and then you find the baby's head, and then you basically go and twist this little, it's like a little pin, like a spiral pin electrode, and just kind of twist on top of that baby's head. It pokes them, but like not anything major. So it doesn't hurt them per se. So it basically just tells you exactly what that baby's heart rate is, because you can tell from the head, like the pulse of the baby by just putting this little thing in their head. So if the mom has a little bit more fluffy abdomen, or it's just hard to keep the baby on, then we put this on so we can know exactly more what the heart rate is doing, because you have to know what the heart rate is doing at all times, because something could go bad, and you need to get that baby out if the heart rate stays down too low. So this is an IUPC. So you see the bottom where it says big pretty hills. Those are called the contractions. So we monitor contractions, but usually we have these little round things that go on outside the stomach, and so your uterus obviously gets bigger and bigger as baby grows. So we put it on top of the uterus. The fundus is what it's called, and it monitors the pressure. So when your fundus gets harder, that makes the hill go up, and then once it releases, then the little monitor can notice that the pressure is going down, so then the hill goes down. So it's pretty cool, but it doesn't tell us exactly how strong they are. Even those hills look pretty like they're strong contractions, unless you have an internal lead, and this just basically goes inside the vagina, through the cervix, and up into the uterus, and it just literally sits beside the baby's head in the uterus, and it monitors the exact pressure of how strong the contractions are. So it's pretty cool that we can do that, because it's helpful, especially if you have a mom that's not progressing, changing cervical dilation. You can tell whether the uterus is doing its job, or it needs some help with some a medication like Pitocin to make the contractions stronger. So that bottom monitor is kind of what we look at for heart rate, and it tells us how strong the TOCO is getting. Also, we have the blood pressure. We monitor blood pressure, heart rate by that machine, and also there's a temperature probe connected to it that you can do all assessment vital signs with that little machine that's pictured right there. So it's pretty cool, pretty handy. It actually is pretty nice because it makes charting easier too, which I hate charting, but it's part of the job. So it makes it easier because you can literally just click the vital signs over into the patient's chart. So it's pretty nice. Let's see, provides appropriate nursing care for childbearing women from teens to advanced maternal age. It's not uncommon for having teenage pregnancies. I've taken care of several teenagers. I think the youngest was probably 14. But also that's just because you're young and healthy doesn't mean there's no complications of getting pregnant that young, because it's hard on your body. Pregnancy is very, very hard on your body. So thank all your guys as mothers. So just having that support, and also they might be shocked and not knowing what to do, need that support. They might think about adoption. They might want to keep the baby. So there's definitely a ton of education that's needed for this age group. Not that they can't be good moms, because there's some really good teenage moms out there, but it's just harder. So just lots and lots of support and love to those teenage moms. And then advanced maternal age, obviously, let's see, I think it's 34 or 36. I can't really remember the cutoff on advanced maternal age, but once you get pregnant at that age, it's also more risk of having complications during pregnancy and delivery. A lot of times hemorrhaging, which means bleeding too much. So it could be a complication of any delivery, but especially when you have risk factors. So hemorrhaging could get bad really quick. So all that blood supply, because that uterus was stretched out for 9 months, and then after that baby's out of there, it starts to go down, but sometimes it doesn't go down quick enough, and so it bleeds and bleeds and bleeds, and so you just need to, there's medication to help stop it, but also surgery can stop it as well, but we try not to make it get there. We try to fix it with medication, but hemorrhaging is definitely a risk of maternal complications, and also is a big leading cause of death for moms in the United States. So provides advocacy, education, and care from pregnancy through to postpartum phases, including fetal and infant care. So if they come in for outpatients and everything, a lot of times the biggest thing about pregnant moms is they don't drink enough water. So water, not drinking enough water, giving that baby hydration and mom hydration, because it does create a huge stress on mom, can lead to things like urinary tract infections is really prevalent in pregnancies, also preterm labor. If you don't drink enough water, that can lead to that. Just in general not feeling good because your blood pressure's low, because you're not having enough fluids, or just a lot of things that can happen from not drinking enough water. So it's definitely important to educate early and often. So also knowing what to expect, like when it is labor time. A lot of moms think, oh, I'm in labor, when they're contracting, irregularly or whatever, but it's very important to tell them it's not labor unless it's consistent contractions, and they're at least 5 minutes apart or so. So let's see. Also, like when they go home, just education on infant care, like no bath until the umbilical cord falls off, circumcision care. So just things to watch out for that, how to take care of the baby for that, and then advocates for in-room or single-room family-centered care. So there was a push several years back. You used to know the nursery from the movies, where all the babies would be in the nursery. We don't do that anymore. A lot of the push has came from the breastfeeding movement. So the babies in the room more often. The baby can, get latched more often, have skin to skin, which helps with breastfeeding, and just having that access to the baby, and the baby and the mom and dad picking up on cues that the baby's hungry, to be able to go and feed them more often. So a lot of push for in-room family-centered care, and it's very important because this is a family experience. Obviously, everybody's involved, everybody cares. It's pretty cool when pre-COVID you could have all the families in the hospital, and they could help the mom and dad out by maybe taking a nap, bringing them food, just loving on the baby, all that kind of stuff. So it's an exciting time for everybody. What's it like to be an L&D nurse? So we triage patients. They come in, we check them, we check their cervix to see if they're in labor, or complaints like they're, maybe bleeding, or they're having urinary tract or signs, or they're having abdominal pain that's not contractions, things like that. We do all the testing and rule out all the serious complications. And some things can be easy fixes, and some things just, there's really not a known cause for things like that happening during pregnancy. Sometimes you're just hurting because your body is stretching out and making room for a bigger baby. So, like I said, checking cervixes. So that's a huge, thing about L&D nursing, because if you check cervixes during labor, if your patient is progressing or if they're in labor or not. So just because you're having contractions doesn't mean you're in labor. It means if your cervix is changing, that means you're in labor. So that's why we check cervixes. So about my finger, if I got my finger inside the cervix, then that would be about a 1. And then you go up and then, get 2 fingers side by side, that's a 3, 5, you just kind of have, and it's kind of objective because that everybody's kind of fingers are different sizes or whatever. A male physician might be a little bit different than a female. So, but basically everybody knows by that chart kind of what your cervical dilation was with your fingers checking. So basically the cervix, I don't know how much you guys know about anatomy, but it's the opening to the uterus. So you have your the bottom of the cervix, and then it just opens up to your uterus. So in order for the baby to get out, that cervix has to fully dilate for that baby to come out of the uterus. So dilation happens when that baby's head is pushing on the cervix, and the contractions help push the baby's head down on the cervix, and that's what causes that cervix just to dilate and squeeze around the baby's head per se. Yeah, it's pretty cool. Our body is amazing. So this, I guess, is a picture of kind of the baby coming out. So just kind of how they keep pushing down, and eventually that's the crowning stage when basically his head's out and then birth. Early labor is considered 0 to 3 centimeters dilation, so baby's pretty high up there, and maybe you can see, maybe you can't, but the cervix is still around that baby's head, causing the baby to stay in there. And then active labor is 3 to 7, and the cervix is wider, so it's about to let that baby get down in the pelvis and birth canal further. So So things that also we do as L&D nurses, if the patient is not progressing, the cervix isn't dilating, we use peanut balls, different positioning, weird positioning, but that helps rotate that baby down, get into a position where it's more on the cervix, pressing on the cervix. So we do a lot of thrones. So we set the patient up in like a frog leg position and drop the foot of the bed down, and that just helps the baby come down more. Also side lying, so we lay them on their side and usually put a peanut ball in between their legs. That just opens the pelvis up and just allows the baby to come down into the pelvis easier. Just different positions like that. You see the women bouncing on the birthing balls. That just helps that baby, come down and, sit on the cervix better, so that cervix will dilate. Reading fetal strips, I already talked about that. Helping patients dilate, talked about that. Coaching through pushing. So, especially first-time mamas, it's hard for them to know how to push. And so you just have to coach them, encourage them during pushing. Let's see. And then also just, be be there for them when it's, you know, a long time pushing and they're getting tired, and they're getting, you know, they're like, ugh, I can't do this. But everybody goes through that. A lot of first-time moms honestly push for about 2 to 3 hours. So it's totally normal for it to be a long time, but it's exhausting. So also, sometimes they are so numb with their epidural that they don't know where to push. So that's a problem, and you just have to help them through that. There's different pushing techniques. Sometimes you can do like a towel pushing. So I've been at the end of the bed before playing tug of war basically with a pregnant mom trying to get that baby out of there. So that's exhausting for the nurse, but it works. Let's see. Ready for an emergency at all times. Obviously, labor and delivery, it's not all, you know, peaches and rainbows. Sometimes it can get real serious real fast, and you just have to be ready to act on that emergency. Things like hemorrhaging, you can abrupt, which is basically the placenta coming away from the uterus, and we kind of talked about how the placenta is that baby's lifeline. So if it comes from the uterus, it's not getting the blood supply and oxygen from mom anymore. So if that happens, then that's an emergency, and you get that baby out of there because the baby's no longer getting anything from mama. Also, if you know the baby comes down in the birth canal, but the umbilical cord comes down with them, and that umbilical cord is getting squeezed by the baby and, you know, mom's body, then that can cut off blood supply as well. It's called a cord prolapse. And so again, you know, you do what you need to do to get back to the C-section room. Sometimes you ride on the mom's bed with them, and you're back to the C-section room with them, and basically you ride back to the C-section room to help that baby's blood supply stay good. So let's see, performing resuscitation on babies. So that's another scary thing that can happen, and you have to be ready when that baby comes out because it might not come out pink and crying. So we have things like this little T-piece resuscitator, and then also a mask that goes on the baby, a little bitty mask that it's called PPV. So positive pressure ventilation, and that air gets pushed into that baby's lung with this little mask. And that's part of the NRP training that I was talking to you about. So you learn all the steps and everything, 1 and 2 and breathe, 1 and 2 and breathe. So then you resuscitate that baby until they become pink and crying and have more tone and stuff like that. So things like it might just need to be suctioned out because baby's swimming in a bath basically, and then when it comes out, sometimes it can swallow the amniotic fluid and need to be suctioned out, and help it breathe that way. The further thing, you advance airways by intubating that baby. I didn't bring a scope, but I brought the ET tube and stylet. So you basically use your little blade and go down the baby's airway, put this in, and then you'll have like either bag mask or a bag to bag the baby with the ET tube in there. We don't have a NICU or like a ventilator at our hospital, so we have to bag that baby. I know there was one night I was huge and pregnant, and there was an ice storm, and we had a baby that was 32 weeks, and we literally had to take turns standing and bagging that baby all night long because the transport team wasn't working. So they couldn't go because of the ice, the road conditions. So that was a fun night. So just basically, it's obviously better for them to be on a machine because you control the settings better and everything like that. But, things happen, and sometimes you just have to do what you got to do, anything to get air and blood circulation in that baby's body. So That's an ET tube, and then an oral pharyngeal airway. If you can't get ET tube down that baby, and the baby will tolerate this basically just goes in the back of that baby's mouth. You blow up the balloon around the airway, and it just basically sits in the back of the throat, and you just blow it up to stabilize it, place it, and then that's how you push the air in, so it doesn't go all the way down the trachea, it just sits in the back of like the throat. It's sometimes not as effective because sometimes you can't get a proper seal, so you're not getting that oxygenation as much as you would an ET tube, but sometimes it's better than nothing. So performing or scrubbing C-sections, so I been there for 5 years now, and so I do all the roles, charge nurse, labor nurse, and scrub nurse. Scrubbing, if you're a scrub nurse, you set up the delivery tables. So I didn't bring any instruments, but I did bring some like tools or whatever. And then I brought some C-section things that we use for C-sections. But you set up those tables. Those tables have to be sterile, so it's a little bit training involved. And you gown and glove with the sterile gown and sterile gloves. So I brought a gown to kind of show, but you know, the typical that you see on Grey's Anatomy or whatever you guys watch. But it's fun. You have to maintain the sterility at all times. You hand the tools to the doctors to help cut open the mom and get that baby out of there, and then help sew her back up and load the sutures and all that kind of stuff. So it's fun. That job is can sometimes be stressful too, because you have a mom or baby that's crashing inside. You have to get that baby out fast. So sometimes you just open it and, you know, just do your best to keep it sterile. But sometimes that doesn't happen, and that's why I got invented antibiotics. So let's see. We also do 24-hour testing. So I was telling you about cardiac screening. So if the baby feels that, you basically put a pulse oxygenation SpO2 reader on their hand and then their foot. So it measures if the oxygenation is the same between both of those, because if not, then there could be a cardiac defect. Things like PKU, so you have to prick the baby's heel to get some blood, and that test if the baby's metabolizing food properly, because if not, then that can cause some major issues. Also test for cystic fibrosis and other things kind of like that. Let's see. Bilirubin, so you guys probably have heard of jaundice before. If a baby's jaundice and the bilirubin level's too high, which is broken down by our liver. Babies' livers are immature, so they don't sometimes break it down as well. How you get bilirubin out is by pooping it out. So if a baby is not eating good, or they're just, you know, a premature baby or whatever, sometimes they struggle with having higher bilirubin levels, which can cause them to be jaundice. Jaundice in itself is just a sign of high bilirubin. High bilirubin can cause neurotoxicity to the infant, so that can be serious. So things like cerebral palsy can be caused from high bilirubin levels for too long, and all that kind of stuff. So we test that usually at 24 hours, but if not, if they're higher risk, like Hispanics or premature, or just like things like that, then we test at 12 hours, because we want to get on top of it so they can get under Billy lights sooner, and break that, help the Billy, so the Billy lights are the UV lights, the blue lights that you see, and that just like a baby tanning bed basically, that helps breaks down the bilirubin inside the baby's bloodstream. So giving their babies the first bath, that's always fun. Helping mom get comfortable, and recovering mom after birth. So all the cleanup, helping her get up for the first time, showering, help her feel like a normal person again. You go through a lot having a baby, so let's see. That's the picture of a peanut ball that I was telling you guys about, that I use a lot because it's been proven actually to decrease the need for a C-section rates. Things that also, that for delivery, while we're talking about delivery, this is called a vacuum. If the mom isn't able to push that baby out, but she's dilated and baby's doing good, or she's almost there, like the baby's crowning. I showed you that picture of the baby's crowning and she just needs a little bit of help. The doctors put this on the baby's head and help kind of pull that baby out of there with the mom's help pushing still. So this also has decreased the need for C-sections. These aren't my best friend, but they still have their purpose. The bad thing about these is that they can cause like a big like bruise and jelly-like hematoma on the top of the baby's head. So it can be harmful if you use it wrong, but most of the time that bruise goes down pretty quickly, like in the 4 to 5 days, or sometimes even less, depending on how bad it is. During labor, again, this is something the doctors usually just do, but if they're not progressing and they still have their water sac intact, this is called an amnio hook, that the doctor goes in the vagina and then finds the baby's head. If the baby's head is low enough, then they'll go ahead and just take this little hook and break the amniotic sac. That way the baby can come down further. If it's too high up and they do that, one of the complications that could happen is a cord prolapse, and like I said, that could be bad. So you have to use this very carefully and know when to use it. Sometimes moms' waters break on their own, and other times they need help with that. So let's see. I think that's all I want to talk about on that. Pros and cons of L&D nursing. You have the rainbow babies, like, so moms had miscarriages and then they get pregnant, and the baby is very exciting. Every baby's special, but it's just something about those rainbow babies that they were really special. But on the flip side of that, you have the demises and miscarriages. So demise is technically a term when the baby can be viable. So viable means just after 23 weeks. So baby can more so function outside mom's uterus and womb than they can less than 23 weeks. So if it's after 23 weeks, we call it a demise. But if it's 4, then it's a miscarriage. But it's sometimes they can even get to 38, 39 weeks, and they come in, they're not feeling baby move or whatever, and usually baby doesn't have a heartbeat, which is really, really, really hard. So that's a con. Concerned parents, you have those awesome parents that are always concerned, oh, what about my baby's test, or all this kind of things, how's my baby doing? And then you have the moms that come in drug positive, which can kind of be a little bit heartbreaking, but also you just have to feel for them too. So supportive families are nice, and then you also have the family drama. So you have these stories that it's not just Jerry Springer. It happens in real life, where you have a mom come in and her boyfriend's with her, but also her husband or whatever. So it really happens. So let's see. You get to celebrate the best moment of someone's life with them. You get to help bring life into the world. I still cry a lot of deliveries, especially if they're special or whatever. So it's always special bringing a baby into the world. You get to work 3 days a week, 12-hour shifts, but you're done in 3 days a week. So that's a huge perk of nursing in general. Flexible schedule. A lot of places you can pick your own schedule, and it's nice. So if you wanted to work 2 on, work 1 off, and then work another one, or you have 3 days in a row, but you get 7 days off before you work your next. Sometimes even I think you could even swing it to work 10. I can't remember how exactly how that works, but you can get basically a vacation done in a week if you work your schedule right. So, also this job is an adrenaline rush because you have two lives at stake at once, and things can go bad really quick. So, you get to use your critical thinking skills. I love that when you have a triage patient. It's really nice because our doctors trust us, and we basically can start an IV without them telling us to, do testing, run certain tests, do certain things, collect swabs, all that kind of stuff without their orders. Because you come in, they're complaining of X, Y, and Z, and you're like, okay, I know what I need to do, this, and that. So it's pretty cool to be able to use the brain that God gave you. So different rules so you don't get bored. So like I said, I do scrub nurse, charge nurse, and labor nurse, and it's kind of nice to have different things that you get to do every day, taking care of the moms and babes or taking care of a labor and induction patient or whatever. So some other cons, you have to take call a lot of times being a labor and delivery nurse, because sometimes all the moms decide to come in at once, especially on a full moon or like a rainstorm or something. So definitely call is needed. You have to work weekends. With the weekend option, you have to work less weekend. I know that a lot of my friends that I work with, they maybe have to work 3 weekend shifts, like either like 2 Saturdays and a Sunday every 6 weeks or whatever, but a lot of them just have to work 3 weekend shifts, which isn't bad. And then also 12-hour shifts, so get your those long days sometimes, but at least they're worth it because you only have to work 3 days a week. Also with the flexible schedule, there's PRN nursing, which is as needed. So you basically get to pick up the shifts that are needed or just pick up as much as you want to. So that's really nice. And then there's part-time. So you just have to work 2 days a week, 24 hours basically a week. And usually, I don't know if it's $18 or $19 an hour that you start out as a new nurse, so not bad. So for just 2 years of college, basically 2-3 years of college. I think that's all that I have. I think I pretty much showed you guys a lot of things. So any questions? Yes. So usually it depends. So it depends on how low the baby's heart rate gets. We don't usually like it dropping below 90, but even if it's below 100 or below 110 really for a long time, we think about C-section. Or if the baby's heart rate is too high for too long, that also can mean the baby's stressed out. And just needs to be out of there, like usually it means infection or baby's working too hard inside. So it depends, but usually we have what's called prolonged decelerations, which I said decelerations are bad, and that's just the heart rate staying down for more than 2 minutes. And so usually, especially if that's recurring, that baby's getting out of there. If mom starts bleeding or like having abdominal pain that's pretty severe, and they start bleeding, then that's probably a reason we get out too. So there's different reasons, but mainly we just watch that baby's heart rate like a hawk and, decide from there. So, yes.
How did you decide that you wanted to do labor and delivery over
Any other else? So actually it's kind of funny because I was sitting exactly where you guys are, and Courtney Gates, which still works in labor and delivery, came and talked to us when I was in Health Walk, and she was just so excited and loved her job so much. And I think that, I can't remember if I think I put that, maybe I didn't, about you have to have a love for labor and delivery nursing, and it just a passion for it and everything like that, because it can be hard, it can be really stressful. But I think that I wanted to, right after school, I went to med-surg like for 6 months, just to get my general nursing skills kind of down. And then I decided there was a job opening in Monette, and I just knew that that's always what I wanted to do, and I was passionate about it. So I think that's kind of how I chose it. So yes.
Ever dealt with like triplets or?
Twins. Triplets I actually dealt with once, and that was when I was training at Cox South for labor and delivery. But they didn't deliver on us. She was in the like antenatal unit, so like before pregnancy, like that we were just trying to keep the babies inside her for like at least 2 more days. She was trying to go into labor, but we were trying to prevent that from happening because she was a little early. But yeah, I dealt with triplets one time up there, but mainly just twins down here. Delivered twins a few times. But yeah, triplets can kind of get a little crazy, especially trying to keep up with their heart tones. Yes.
How do you deal with the families whenever their babies don't make it?
When their babies don't make it. We have a lot of different things that we do for those families. We take pictures for them. We still do their footprints. We have a little demise box where we can put like them in gowns or and take their pictures, make little bracelets for them with their names that they were supposed to, have, or they still have. But just things like that we do, and just be supportive. If they, need like counseling help, we have that. You just kind of have to reiterate the fact that it wasn't their fault, because a lot of moms blame themselves if something happens to their baby. And also if they want pastoral, like somebody coming in, like a chaplain or a pastor or whatever, coming in to talk to them, that's always available. But yeah, just be there for them and tell them, that you're sorry, and you're there for them if, and remind them that it's not their fault. They couldn't have done anything different, so.
Do they get irate with you whenever that happens sometimes?
I think they're too, most of the time that I've experienced, they just kind of are just numb to it, and it doesn't really hit them until they go home, sadly, a lot of times, because it's a shock for them, so, but. Yes. Oh, you're right.
How is pregnancy different with
With
twins?
twins, it definitely, like I said, pregnancy is just stressful in general on a woman's body, but you're having 2 things that are sucking the life out of you basically at once. So there's more hormones. It's higher stress on your body just in general, because you gain more weight. You like musculoskeletal, because you're just, you just have this huge belly, and it's just, just hard on your body. Blood pressure wise, blood sugar wise, maintaining that, because like I said, you're growing 2 things at once. So it's like, you have to eat a well-balanced diet and lots of, protein and good snacks and stuff like that to maintain it. So, and it's just higher risk in general, because, sometimes, you have those twins that are sharing the same placenta or whatever like that. Also, that's just high risk for them in general. Or you have the one that one's taking something from the other one. You have that one, this is a really big twin, and the other really small twin. And usually, honestly, the little twin does better than the big twin. So just because of how that works with, just because they're big doesn't mean they're healthy. And we see that especially with single infants too. Just because they're big doesn't mean they're healthy. A lot of times that means that mom's blood sugar was too high during pregnancy, and then they come out and they crash because their blood sugar is too low, because they're used to mom's insulin level being so high to break down all her sugar, and then they come out and they're like, oh, what is this? I have to do this by myself. I don't know how to do this. And so then their sugar is low, so it can be really scary for them. So, did you have something?
Yes. Have you ever delivered a family member or a friend?
A friend. Yes, I've delivered a family member, but I can't go into too much detail because of HIPAA. But I have, and friends, especially delivering or working in Monette. I've delivered people that I know. Yeah. It's, doing what we do, some people can think that's awkward or weird, but it's no different. You're just there and you're doing your job, and it's actually kind of special and, kind of cool. So, yep, but I have delivered people that I know. Yep.
How many nurses are in the room while the baby is being delivered?
Nurses, usually 2. We have 2 nurses because one primarily takes care of the mom and one takes care of the baby. Sometimes we have 3 because 2 are ready for the baby, because if they need resuscitation, like some of the things I was talking about, one has to be doing chest compressions on the baby and one has to be doing the ventilation or whatever, so it takes more hands on deck to take care of sick babies. So if you're expecting like a preterm, like one that you're thinking that might be at higher risk or whatever for needing help, then you'll definitely have 2 nurses in there just ready, just to make sure that you don't need more help, and then the other one's just devoted to mom. And then of course you have the physician who comes in for the final finale. But so also sometimes they don't make it, so you get to deliver a baby by yourself, so that's kind of cool sometimes. Lots of charting and paperwork, but cool. So, yeah. Oh, go ahead.
Are cravings a real thing when you're pregnant?
Yes, yeah, and a lot of it's not because of what you think, it's because your body's usually wanting something, like you're deficient, because like I kind of talked about, it sucks a lot out of you, so you're making a baby and that baby's needing all those minerals, your iron, your all the minerals in your body that they need, so that they get from food, vitamin C, vitamin D, all that kind of stuff, just, and then that makes you deficient. So in order for that to make up with that, your body craves stuff to help make up for that, so.
So what do you do like whenever you're not delivering the baby? What else do you do?
So, and like I kind of said, we take postpartum moms and babes, and then we also do triage. So take care of the moms and babes until they go home, like help them, monitor them still, because you can still bleed. So we do like fundal rubs. So I was talking about the uterus on the top of it. You can tell if the mom is where it's supposed to be, if it's midline, it's firm, and it's like at the belly button. So we assess things like that. We bring them food. We help them with breastfeeding if they need help latching, or just questions about that. So that's a huge part of our job postpartum wise, is basically breastfeeding and feeding support, and just monitoring the baby and all that, weight checks, make sure they're getting enough to eat. Just stuff like that. So, and triaging, patients that come in. But sometimes, I'm not gonna lie, there's days that you just sit there and wait for something to come in because you don't have anything. But usually we've been pretty busy lately, so that's good. So, got something.
Is there like a time of the year when you have
More
more patients?
patients. I think it varies. But let's see. I think usually November is pretty busy. I can't really think. Probably, I don't know, November's pretty busy usually. I feel like October was dead last year, but it's been pretty busy this year. Yeah, I think it just depends, honestly. Yep. You forgot your question.
What was it? I forgot.
You forgot. Okay. If you figure it out, then I'll come back to you.
So basically you're not gonna be helping general patients while you're waiting. So you're not gonna go and help someone that just got out of surgery for fracturing their
For another reason. So our hospital is pretty small, and it's rural health, so we actually float sometimes to different floors. Like I will help in ER, med surg, or whatever in Monette. So it just depends. It depends on if they're busy or whatever, then we'll go help them sometimes. Even just do tech work, like pass trays, or do vital signs for them or whatever. But usually, unless they're overwhelmed, busy or whatever, then we just basically sit and wait and do chores and all that fun stuff. So
What do you do with the moms that have COVID?
that what? Sorry.
That have COVID.
That have COVID. So there for a while, it was kind of scary and unpredictable what was going to happen. Our main thing is having the room. So negative pressure room. And you know, you're in a big hospital and all these vents and airways and all the kind of stuff is circulating through every room. Of course, you kind of heard about COVID, about how they're not really for sure how it's transmitted and all that kind of stuff. So we put them in negative pressure rooms to keep the virus basically inside. We weren't supposed to be taking care of in Monette COVID positive moms, but now that it's becoming more and more, we're taking care of COVID positive moms that aren't symptomatic. So if they're symptomatic, they go to Springfield because there could be like higher risk. But if they're not symptomatic, they stay here. So there was talk about separating mom and baby if the mom was positive and the baby wasn't. But I think that we, just as long as mom remains symptom free and just wearing a mask, that's basically what we do with that now. So we don't want to do that if we don't have to separate mom and baby. So unless she's really sick. So
they can still get breastfed and stuff.
yes, yeah. So that we just tell mom to wear a mask and stuff while she's holding a breastfeeding baby. So yeah, there was talk about that too, about, oh, you can't breastfeed, but yeah, you can. So
So do you get as much time with the patients as you do, like you're talking about how when they enter, like when they leave?
Uh-huh.
Is that just a little bit smaller, or will it be like that anywhere you go?
anywhere you go. So Cox South or like big hospitals, so ours is called an LDRP. So labor, deliver, recover, postpartum. So that's what our unit is called. And then at South, they just have an L&D unit. So they deliver those babies, you stay there for an hour or two, and then you go to second floor, which is their mom and babe postpartum unit. So they deliver a lot more moms though, so they're, getting in a lot more and everything, but we get to keep them through delivery and taking care of them until they leave the hospital. So no, not every hospital is like that, just smaller hospitals. So
Whenever a woman's like in labor and they come into the ER, do they immediately go through? Or they have to wait, like, or they just get to
so our unit, we do triage too. We just kind of do it all. So they have to check in through the ER, but if they're huffing and puffing and they think that they're going to pop a baby out soon, then they check them in later. So they'll go in, check in, and then they'll go straight to us. They don't go through the ER, get triage in ER. They go to us. So yeah, because ER nurses run from pregnant women. So. Triage, okay, so basically you hear of triaging like if it's a minor problem, a moderate problem, or a big problem. So you basically figure out when that woman comes in by her complaints, if it's a serious thing that needs to be fixed right there and now, or if it's something that you can still send her home, if something that she needs to be monitored for longer, like stay for 24 hours to monitor her longer. But if they come in bleeding or hurting, or they're coming and the baby's breech, and her water's broken, those feet are hanging out, into the vagina, and then you're like, okay, we gotta do something now. So basically it just tells you how emergent or urgent the situation is, or if it's just something that, you can give her peace of mind, reassurance, tell her what to do when she goes home, and, things like that, so.
What's the scariest situation you've ever had?
So I think I was about a year into labor and delivery. I had this woman come in bleeding. So sometimes you're like, oh, how much bleeding? So people can think, oh, a little spotting or whatever is a lot. So sometimes you're like, okay, we'll just wait to, freak out until she comes in and she's, bleeding a lot. So She came in, she had been cramping, she hadn't had any prenatal care yet. So prenatal care is when they, come see the physician in the doctor's office, get all their testing, get their ultrasounds, get their blood work, and they just see the doctor just to make sure pregnancy is all well and fine. So she didn't have any of that. She never had an ultrasound. And she came in and she was bleeding, and we did a sterile spec, which I guess I should have brought one of those. But it's just like this thing that goes inside the vagina, and then you kind of open the clam jaw or whatever you want to call it up. It's not as bad as you think, but it doesn't sound good the way I'm describing it though. So then it just kind of opens it up so you can see it better. And then, but like whenever you have bleeding, you never want to put your fingers up in there. So what I was talking about, like checking cervical dilation, you don't want to put your fingers in a bleeding mom because you can make it worse. So by doing the clamps and just opening it up so you can see it better, you can tell if the cervix is dilated any, if she's actively bleeding, if it's old blood, anything like that. You can tell by just getting a better look at it. So that's what the sterile spec is. It just kind of opens up the vagina a little bit so you can see it better. Anyway, so we did that. We see a bulging bag with the baby's head in it. We thought she was around 20 some weeks due to her last period. So we had called, the only thing that was holding that baby, because she was completely dilated. So the only thing that was holding that baby up in there was the amniotic sac that was just holding that baby in there. We called Springfield, which is called the baby buggy, and they came down and they were actually ready for delivery, which is, your weight is lifted off your shoulders when they come, and they're there for you because they're specialized in taking care of the really, really tiny babies. So they're there all as well. And then we go back to the C-section and get the first baby out. They're there so you feel good. They're taking care of that baby. Had a heart rate when it came out. It was like 23, 24 weeks, I think. So really, really small. Not even really the eyes. So different stages and everything of development. The eyes were barely open, so they fuse and then they open whenever they're growing more. So barely that. The skin was really still almost jelly-like, not jelly-like, but just, you could see through it more. And so it was early. But it was doing fine. They were about to intubate and everything like that. And then the doctor goes in and, is getting the placenta or whatever else out. But instead of placenta, she finds another baby. So 2 premature babies that we didn't know about. So then I and another nurse and our respiratory therapist had to take care of that baby, which I had to definitely step out of my comfort zone that night because you had to do what you had to do. Had to bag that little baby, give chest compressions to that little baby. There's the medicine that baby's heart rate wasn't, it was like below 60, I think, when it came out, which that seems normal to us because that's a normal heart rate for us, but babies should really be around 120, 140 when they come out and everything, definitely above 100. So you have to give a medicine called epinephrine, so that helps that baby's heart rate go up. So we had to give that also on both of these babies. So, really, in all honesty, it's really hard for a full-term baby to get an IV in if they need an IV for antibiotics. But these babies, we had to do UVC, which basically premature babies usually cut the cord pretty long, their umbilical cord, and literally a line goes into the umbilical cord because the umbilical cord holds 2 arteries and a vein. So a UVC goes through the vein And so it goes all the way down there and then like into its circulation system, because used to that, umbilical cord was getting its circulation from the placenta, but then you just, when you cut it and clamp it and then it's surviving on its own, you just go right into the UVC and it goes into the bloodstream from there. So that's, what we had to do on those babies is do those kind of lines to be able to get fluid so their blood pressure could be stable, get sugar because obviously they needed to maintain their blood sugar, like sugar water. So usually we do like a D10 or whatever, and that's dextrose, so it's basically sugar. And so do all those kind of things on those babies. They survived leaving our hospital, but unfortunately they died later that afternoon. So I was working nights at that point. That was probably the scariest thing that I've done. So, yeah. 23, 24 weeks, there's not really a high survivability rate, especially if you don't have prenatal care because you're not like preparing for it. But sometimes even so, it's not high. The baby's lungs also, like I was talking about developmental wise, they don't have the surfactant, which surfactant is like this, fluid that goes inside your lung sacs that if your lung sacs aren't opened by that surfactant, then they're collapsed and they're flat and you can't get oxygen in them if they're not open. So that's one thing those babies were lacking, but they did receive surfactant through their ET2. Hard decisions were made because you had to pick which one was doing better, because there was only one dose of surfactant that they brought. So yeah, that was a little hard, but they both did well leaving the hospital. They're just early, but yeah.
Is it common that like teenagers come in whenever they're like 7 months pregnant and you just have to do the best you can
To educate and stuff when they deliver. It's not just teenagers, but we do have people that come in that think that, or they hold off until the last minute or whatever, and they don't know they're pregnant or whatever. Yeah, we do have that happen. Usually I feel like a lot of times they tell like their parents or whatever if they are. So I think that, or somebody, we had one case that this girl came in, delivered, said she was going to a friend's house, and her parents didn't know she was going to the hospital to have a baby, but she had already set up that how like the baby was going to be taken care of and all that kind of stuff. So yeah, that we've had that happen before. So
wow, and like you don't like at that point like you
no.
tell the parents because that's her decision.
Yeah, because when you're pregnant, you're an emancipated minor, so all those decisions are yours, and it would be HIPAA to break that. So once you're pregnant, it's yeah.
They're legally emancipated? Like that's just cool.
Yeah. So no thinking there. So don't get any ideas. Any other questions? You guys have been a good audience. I wish I would have brought candy. I kind of forgot I was going to do that, but.
Do you enjoy your job all the time? Is it not something you don't get bored of it?
Like I said, I think, I don't really get bored of it. It's pretty cool all the time. Well, not all the time, but like there's always a challenge and everything. So, and different things that come up, and using your critical thinking skills and everything like that to help a mom not have a C-section, or to help her, like if they're struggling on breastfeeding or whatever. So it's just always have to be on your toes and think. So.
Do you ever have moms come in and they don't want their child?
Oh yeah.
What do you have to do?
There's usually a plan. They usually already have that worked out. with family members or, applying for adoption agency, but we can hook them up with an adoption agency if that's what they want to do. That's one of the questions actually we ask when they come in, if this is a surrogate pregnancy or if they're planning on adoption or they're planning on getting their tubes tied after this or whatever. That's just all part of when they come in, we ask them those questions, so.
Do they ever like refuse to take care of the child?
Yes, and in those cases, obviously, the hospital just kind of takes over care, so, yep.
Do people ever faint while you're in there?
During epidurals, more dads faint than moms. We've had to take dads to the ER to get stitches in their heads because they fainted during the epidural, so. But yeah, that more happens than often moms, so, yep.
So, like, sorry, I have a few questions. Whenever you go in, like, do you just ask them ahead of time if they had like a natural birth or if they like an epidural? Like, do you ask them?
Yeah, their birthing plan is also something that we talk about when they come in for labor, even just triage. We just ask them whether they're planning on natural, like getting an epidural, or they just want Stadol, which Stadol really isn't a pain. It just basically makes you not care and relax. But just kind of their birthing plan, whether they, want minimal badge exams or music, light, slow, stuff like that they can have, and they choose to. For their pregnancy. It's their delivery, they can have a birthing plan, but don't do birthing plans, they always go bad. Oh, yeah. What did you say, sorry?
Like if they're not taking care of the baby while they're there
Yeah.
and don't want to, do they still want the baby or whatever?
Yeah, that's a good question. So you also have parents or the drug moms that also play the part that they want this baby and they want to keep this baby and they're going to get clean or, this, that. But a lot of times they don't take care of the babies or they constantly want the nurse to take care of them so they can sleep. Sometimes we are nicer than others and also it kind of helps them burn their own bridges. If they aren't taking care of the baby and they're not showing us that they can take care of the baby, they don't have the resources or they're not bonding, then we would definitely probably do a social service consult or even call child support services on them and then just take it from there. So, yep.
My aunt gave birth to a baby when she was on drugs, and they didn't even let her see her baby. Like, they just.
Yeah. Actually, usually we let the moms room in with their babies, even if they're drug positive, but a lot of times they choose not to. They choose to go home and leave the baby with us. But as long as they're being appropriate and they're not being acting crazy or whatever, then they're more than welcome to stay until that baby goes home. Yep.
What do you do whenever they're drug induced? I think I've heard of that. Like they give birth to a baby because they've taken so many drugs that's caused
Them to go into labor. Yeah, and that's a huge risk factor for early preterm delivery is actually drug use, and also a huge risk factor for abruption. That's what I talked to you about. So, especially like meth, cocaine stuff, all that kind of stuff is or meth vasoconstrictor. So it causes all that, and then the uterus is full of blood supply. It's a muscle, so all those veins and arteries are constricting and then cause the placenta to tear away from the wall of the uterus. So that's a huge cause. Actually, drug use is a huge cause of abruption. Not the only cause, obviously, but yeah, and then preterm labor. So yeah, it's not uncommon for that to happen for sure. So. Withdrawals, yeah. So that's actually changed recently. We used to do NAS scoring, neonatal abstinence scoring, and depending on how high the number, depending on the intervention. So just comfort measures usually is what we would do. Keep the lights low, the sound low. They like to suck a lot when they're withdrawing. They're really irritable and cry high-pitched cries. They have diarrhea sometimes. It's just signs of like normal withdrawal for adults is going through a baby. They're really, they're tremors. They have tremors and they very either disturbed, or even if you're holding them and they're swaddled, sometimes they just like the uncontrollable tremors that they have. We actually got blessed with a mamaroo. It's like a little swing that goes back and forth for our unit. So a lot of times we'll put the lights low, make sure the sound's not high, or like the volume of the sound's not high in the environment for them, put them in that, and we just, we'll rock them and everything. Sometimes that's not enough, but it definitely helps them. But yeah, so basically all those things, but sometimes they're in a lot of pain, and especially if it's like an opioid addicted mom, they'll go to South and they'll get actually morphine to help them with the withdrawals. We don't do that in Monette anymore, but they definitely get morphine, but meth, even the morphine doesn't help them because it's not an opioid, it's a different drug, so it wouldn't help them with the withdrawal. Sometimes we often encourage the mom to actually breastfeed because they're still getting a little bit of that drug. Kind of seems weird, but it actually helps them through that withdrawal process, is getting a little bit of that. Obviously, we wouldn't want them to continue to breastfeed when they leave the hospital because we want to eventually wean that baby off of the drug, but it helps kind of take the edge off for the baby just to get a little bit of what's in the mom's system, still kind of help with the withdrawal.
So, whenever this stuff happens, is there people that work in the healthcare that get very upset at the mother and choose not to deal with that, or is that just something that they just have to work with?
Like if the mom chooses to do drugs or to give away her baby.
Like whenever the mom comes, I would only imagine it would upset people whenever there's a baby that comes in and their mom is on drugs and their baby's now on drugs.
Yeah.
How do you guys handle that?
It's hard, but you also have to, like I kind of said at the beginning, it's taking care of the mom and baby and patient, family-centered care. You have to not go into the fact of how can you do this, but also I'm a firm believer in that you don't know what choices that you would make if you were handed the same cards. So I am a firm believer in, not judging somebody if you haven't walked in their shoes. So to be a good nurse, I think you have to have that mentality and to be able to take care of them in the way that they need to, because they're obviously struggling and trying to find a way to fix their pain by using drugs. So, but.
You guys have anything else? You guys have great questions.
Yeah, that was good. Yeah.